following information is uh, some generalized things that I want everyone to be aware of when we are working with adolescents and school-age children. So let's first talk about the school-age child. One of the things that we always want to do is remember that with any child coming into the hospital or a clinic setting, one begins to collect data and information about the child and the family right upon our first introductions to them. When we have a school-age child, it is important to begin to think about addressing the children at that point directly. Introduce yourselves to them, begin to have discussions with them, and ask them questions before addressing questions specifically to parents. School-age children will appreciate that, and it will also give you some indication of the demeanor, the temperament of the child, the social skills of the child, as well as the relationship with the parent. So for example, every time a school-age child answers a question, if they are being corrected by an adult, that caregiver, that can be somewhat concerning and give us some indication of the relationship the child and the parent may have. And that concept, it rings true with any age group when we are beginning to interact with the children directly, so school age and adolescent. It is important to remember that we are always practicing in a family-centered care fashion when we work in pediatrics, which means we involve the family as the child and family define themselves. We always work with those extended family members as much as possible in order to make the experience of healthcare as well as growth and development be as supported as possible through the family dynamics. So a quick refresher, the school-age child is anyone aged 5 to 12 years of age. Once we hit the school age range, we are seeing the children in clinic settings much less frequently. The recommendations by the American Academy of Pediatrics are for one visit per year from the ages of 5 to 12, and then only on an as-needed basis when the children are sick or have an injury. Some general observations that we do want to take in about a school-age child. Generally, at about the age of 5, children are entering kindergarten. That is the first time that we are seeing them for those school-age visits, and we are verifying immunization status with these children at this point in order for them to enter that school. That is also the age where we first begin to see, and maybe even slightly earlier, but generally in the school-age child, they have begun to connect the healthcare visits with needles and shots. And so that question may come up almost immediately when the child is greeted by you at the beginning of the visit. I have often been asked, do I get any needles today as I'm bringing children back? And my general response to that is, I don't know. Let me take a look. We'll look at that later, and immediately distract and discuss, maybe let's go see how tall you are, how much you weigh. That way, I am not having a child sit there worried about the fact that they are getting shots throughout the entire exam. If they have stress and anxiety because of potential shots throughout that exam, my whole exam is going to be skewed, and I won't get a full and fair evaluation of the child. So again, deflect, distract, and not directly answer those questions about needles and shots. Don't lie, but we don't need to answer that question in quite the same way as maybe we would with an adult. I also make sure we do ask about any dynamics in the family that have changed, any complications that have occurred, any concerns that the family may have, and begin to ask questions about whether there is school nurse involvement as children begin to enter those school age years. Many children are managed daily by a school nurse. In the adolescent, much of the same information reigns true. Adolescents are seen very sporadically, and generally if we see them, it's because they have a minor injury, they need a sports exam, or birth control methods need to be discussed. World Health Organizations made it very clear that providers of adolescent health care need to follow certain tenets. We need to be adolescent responsive and not adolescent reactive. We need to be ensuring that we do everything possible to ensure universal health care for adolescents. Providing means that are adolescent friendly for achieving healthcare supports. That would be things like electronic records or mobile healthcare. And making sure that those who work with adolescents are competent in understanding when working with that age. So one of the greatest concerns about the adolescent population is that this is the time frame in their lives where much of what they do, they are developing habits for later in life. So while this is the time where typically those health practices become a little more solidified, it is also the time where they are risk-taking. It is the time when they are sort of testing boundaries and beginning to identify who they are as a young adult and what they want to be. So those two things coming together can be somewhat difficult to work with, and it's something that those of us who work with adolescents need to pay close attention to and address as much as possible. With adolescents, it is just as it is with school age when it comes to family. Did the adolescent come with family members? Did they come alone? Did they bring a friend? Those observations can be very telling in terms of how the family dynamics are, how important friendships are to that adolescent. Remember that adolescence is a time when peers are more important in many cases than family members are. Additionally, we want to make sure that all adolescents understand they can ask questions at any time, open up the door of communication, and ensure that the adolescent gets private time with the caregivers to ask questions and be asked questions so that they can respond honestly. We always want to reassure families that they indeed will get time with us as well in the absence of the adolescent. Healthcare exams for an adolescent are generally healthy exams, well-child visits or well-adolescent visits. However, we do begin some screening processes in the school age and in particular the adolescent age with scoliosis, anemia, because obviously at this age young ladies have developed their periods and may be at risk of anemia. STIs, we are checking at this point when warranted. If the young adolescent is indicating they are having sexual intercourse, we will be testing for STIs. And then, of course, as always, vision and hearing screenings continue. So generalized nursing interventions for school-age children and adolescents, they're very similar, and I always look at the summarized plan, emphasize, so summarize for families and school-age and adolescent what you have found during the visit, strengths that they may have should be recognized, areas for improvement should be discussed, and talking about what to expect in the future as the school-age child and the adolescent begin to grow and develop further. Additionally, we want to provide the families with understanding that adolescents and school-age children are testing independence, and in order to grow and develop and be a functioning human being, we do need to have to test that independence. We need to discuss, especially with our adolescent population, healthy relationships, both as friendships and as intimate relationships, and just define for them what a healthy relationship means. At this age bracket, websites, YouTube channels, various types of apps are really very helpful and something that young adolescents and older school-age children can refer to at a later date for information and supports.